With hypertrophic pyloric stenosis, hypertrophy refers to an increase in size. Pyloric refers to the pylorus, which is the tissue between the stomach and the duodenum, and stenosis means narrowing. So hypertrophic pyloric stenosis, or HPS, is a congenital condition where a baby's pylorus grows in size such that it narrows the tiny opening between the stomach and the duodenum. The pylorus itself has two parts to it: the pyloric antrum, which connects to the body of the stomach, and the pyloric canal, which connects to the duodenum. At the end of the pyloric canal, you've got the pyloric sphincter, which is a ring of smooth muscle that contracts and acts like a valve, letting food pass down into the duodenum, but not go back up into the stomach. In HPS, babies are born with a normal pylorus, but within a few weeks after birth, the smooth muscle of the pyloric antrum starts to undergo hypertrophy and hyperplasia, meaning an increase in the size of each cell as well as an increase in the overall number of cells, respectively. This causes the pyloric antrum to nearly double in size, and this thick, muscular antrum obstructs the pathway of food, which makes it harder for food to leave the stomach and enter the small intestine. Clinically, the enlarged pylorus can be felt as an olive in the right upper quadrant or epigastric region of the abdomen, which is just above the umbilicus. Also, there's normally contraction and relaxation of the smooth muscle lining the stomach, a process called peristalsis. Obstruction from HPS can cause the stomach's smooth muscle to have to work a lot harder to push food through, and sometimes there can even be a hypertrophy of those muscles as well, which can result in peristalsis that can be felt or seen. If food can't pass through the pylorus, it quickly starts to build up to the point where it has nowhere to go, which can lead to vomiting. This usually happens around 2 to 6 weeks, and can get more intense over time, until it ultimately starts causing projectile vomiting, called that because the vomit literally launches out of the child's mouth. The vomit's also non-bilious, meaning it doesn't contain bile, which makes sense since bile secretion happens after the pyloric sphincter in the duodenum. This vomiting leads to a loss of stomach acid, which leads to dehydration, as well as a loss of hydrochloric acid, which depletes the body's chloride and leads to hypochloremia, low chloride in the blood. Also, due to having a lowered blood volume from dehydration, the kidneys retain salt and excrete potassium, which results in hypokalemia, low potassium in the blood. Hypokalemia results in a movement of potassium ions out of cells and hydrogen ions into cells, as well as secretion of hydrogen ions and reabsorption of bicarbonate ions in the kidneys. These effects all tend to decrease the acidity of the blood, in other words, increase the blood's pH, which results in metabolic alkalosis. The precise cause of HPS isn't known, but likely involves genetic and environmental factors. For example, it's more likely among infant boys, and more common among firstborn children. It's also been associated with exposure to macrolide antibiotics. Now, the diagnosis of HPS is usually based on identifying serious vomiting in an infant that's a few weeks old, and feeling a small mass, or an olive, or beginning to see stomach peristalsis on a physical exam. At that point, imaging studies like an ultrasound or X-ray can be used to confirm the disease. In addition, lab studies will classically show hypochloremic, hypokalemic metabolic alkalosis. Treatment typically initially involves good hydration and ensuring good electrolyte balance. But the definitive treatment is a pyloromyotomy, also known as Romsted's procedure, where the muscles of the pylorus are cut and separated, allowing food to pass through more easily. Alright, as a quick recap, hypertrophic pyloric stenosis is a congenital condition where a newborn's pylorus undergoes hyperplasia and hypertrophy, leading to obstruction of the pyloric valve, which causes vomiting that might be projectile, as well as dehydration and metabolic alkalosis. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
The esophagus is a 25 to 30 centimeter long tube through which foods and liquids pass from the pharynx to the stomach. The esophageal wall is composed of 4 layers. Inner mucosa, which is made up of stratified squamous epithelium, except at the lower esophageal sphincter where it joins the gastric epithelium to form the gastroesophageal junction. Submucosa, a muscular layer made of skeletal muscle in the upper third, smooth muscle in the lower third, and a combination of the two in the middle, and finally, an outer layer of connective tissue called adventitia. At the top and bottom of the esophagus, there are the upper and lower esophageal sphincters, respectively. Both relax during swallowing to allow the passing of food or liquids propelled by peristaltic contractions. Additionally, the lower esophageal sphincter also prevents acid reflux from leaving the stomach between meals. Some esophageal disorders are functional, meaning that they affect the muscles and nerves which control the motility of the esophagus. Whereas other esophageal disorders are mechanical, meaning that there's something within or just outside the esophagus that's blocking the passageway. With esophageal dysphagia, it's important to know what type of food produces the symptoms. If dysphagia is related to the ingestion of both liquids and solids, the most probable cause is a functional disorder. On the other hand, dysphagia for solids only means that the lumen of the esophagus is really narrow, often less than 13 millimeters, due to a mechanical cause like a malignancy or esophageal stricture. Dysphagia can also be intermittent or progressive. Usually, intermittent dysphagia is related to both solids and liquids and appears in functional disorders, whereas progressive dysphagia means that something is growing inside the esophagus and dysphagia gradually worsens. Esophageal dysphagia also needs to be distinguished from oropharyngeal dysphagia. With esophageal dysphagia, the individual can easily initiate a swallow, but after a few seconds will feel a lump in the throat. Whereas with oropharyngeal dysphagia, the individual has difficulty in initiating a swallow, most commonly due to a nerve or muscle damage in the upper sphincter of the esophagus or pharynx. In some situations, there can be retrosternal chest pain, and in that situation, it's important to do an electrocardiogram to rule out cardiac ischemia. In order to diagnose the different types of esophageal disorders, 3 things come in handy: an upper gastrointestinal tract radiography, or a barium swallow, an upper gastrointestinal endoscopy with biopsy, and a high-resolution manometry, or HRM. A barium swallow is a non-invasive X-ray of the esophagus, stomach, and duodenum, using orally ingested barium as contrast. Upper endoscopy is a minimally invasive procedure that helps visualize the esophagus, stomach, and duodenum through a flexible tube with a camera inserted in the mouth. Upper endoscopy should generally be performed in individuals that prevent dysphagia in order to rule out esophageal cancer. Esophageal manometry is used to diagnose functional disorders. The way that it's done is a sensitive pressure catheter is inserted through the nose and sent down into the esophagus so it can measure the strength of peristaltic contractions, as well as the pressure in both esophageal sphincters during swallows. There are actually 2 types of esophageal manometry. In classical manometry, there are 4 to 8 pressure sensors placed at different levels of the esophagus, and a normal reading looks something like this. In high-resolution manometry, there are more pressure sensors, and the reading is color-coded and looks like a surface map, where red indicates the strongest contractions, and blue indicates the weakest contractions, so that it looks like something like this. Now, let's go over the functional disorders of the esophagus. With achalasia, esophageal peristalsis is impaired, and food isn't effectively propelled through the esophageal body. In addition, the lower esophageal sphincter doesn't completely relax during swallowing, so it doesn't allow food to pass through, leading to dilation of the esophagus. Individuals typically have progressive dysphagia for both solids and liquids, regurgitation of undigested food, chest pain, heartburn, and weight loss. On a barium swallow, the esophagus looks dilated and has a narrow lower sphincter, classically called a bird's beak appearance. An upper endoscopy doesn't diagnose achalasia, but it should be done in individuals with dysphagia and weight loss to rule out an esophageal cancer. High-resolution manometry is a gold standard for diagnosing achalasia, and it can show absent peristalsis in the esophageal body and high pressure in the lower esophageal sphincter. There isn't a cure for achalasia, but there are options for relieving the symptoms and reducing the pressure of the lower sphincter. The most effective option is a Heller laparoscopic myotomy. That's where a small cut is made in the lower esophageal sphincter to relieve the pressure, and sometimes it's accompanied by Nissen's fundoplication surgery to prevent acid reflux. And this can work for more than 10 years. Individuals above the age of 40 are considered high risk for myotomy, so they're usually treated with a pneumatic dilation instead. That's where a balloon is inserted through an endoscope in the lower sphincter and filled with air for 40 to 50 seconds to stretch out the muscle layer of the lower sphincter. That typically works for up to 10 years. Individuals older than 65 years are poor candidates for these surgeries, so they are often treated with a botulinum toxin that's injected directly into the lower esophageal sphincter through an endoscope. That typically works for up to a year. Medical therapy is a generally ineffective treatment for achalasia, but it can be used in poor surgical candidates if botulinum toxin injections didn't work. Options include calcium channel blockers, such as nifedipine, and sublingual nitrates, which decrease pressure in the lower esophageal sphincter. With diffuse esophageal spasm, peristaltic contractions of the esophagus are intermittent and uncoordinated, which leads to ineffective contractions. In most cases, there's also incomplete relaxation of the lower esophageal sphincter, just like with achalasia. Individuals often have retrosternal chest pain due to high-amplitude contractions and intermittent dysphagia for both solids and liquids, but rarely have food regurgitation. On a barium swallow, the esophagus will have a corkscrew or rosary bead appearance. Again, high-resolution manometry is the gold standard in diagnosing diffuse esophageal spasm, and it shows uncoordinated, high-amplitude peristaltic contractions. Treatment is very similar to achalasia, but in this case, medical therapy with calcium channel blockers and sublingual nitrates are first-line treatment because they're more effective. Pneumatic dilation and botulinum injection therapy can be used in severe situations, but just like in achalasia, they're only short-term measures. With esophageal scleroderma, the smooth muscle in the esophagus begins to atrophy, and as a result, the peristaltic contraction in the mid and distal esophagus are absent. In addition, the lower esophageal sphincter pressure is lower than normal, and that leads to gastroesophageal reflux disease. Scleroderma, or systemic sclerosis, is an autoimmune disease in which there's fibrosis of the skin and the digestive system, particularly affecting the esophagus, the kidneys, heart, lungs, and muscles. Crest syndrome is a limited form of the disease, and it stands for calcinosis, which is calcium deposits in soft tissues, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, which is skin tightening, and telangiectasia, or spider veins near the surface of the skin. Most individuals with esophageal scleroderma have dysphagia, odynophagia, heartburn, and regurgitation. The barium swallow can appear normal, but an upper endoscopy with biopsy may show evidence of muscle atrophy and fibrosis. High-resolution manometry shows reduced esophageal peristalsis and low pressure in the lower sphincter. Since the smooth muscle of the esophagus is atrophied, treatment relies only on controlling gastroesophageal reflux systems with proton pump inhibitors such as omeprazole. Moving on to mechanical disorders of the esophagus, with Schatzki's ring, a thin symmetric mucosal band forms, most often in the distal esophagus, and it can narrow the lumen, and in most cases, a hiatal hernia is also present. The exact cause is unknown, but a Schatzki's ring can be associated with eosinophilic esophagitis and hiatal hernia. In most cases, the individual has no symptoms, but if the lumen of the esophagus is smaller than 13 millimeters, individuals can have intermittent dysphagia for solids. On a barium swallow, Schatzki's ring is often seen as a small and regular ridge above the diaphragm that narrows the lumen of the esophagus. On an upper endoscopy, it appears as a thin circumferential membrane that projects into the lumen. The main treatment for Shiatsky's ring is pneumatic dilation, but often the problem can recur over time, requiring a repeat dilation. Long-term medical therapy with proton pump inhibitors is often added to prevent acid reflux. With esophageal webs, a thin membrane made of squamous epithelium projects into the lumen of the esophagus, but unlike Shiatsky's ring, an esophageal web is mostly found in the upper third of the esophagus, and it doesn't occupy the entire circumference of the lumen. Individuals often have intermittent dysphagia depending on how narrow the lumen of the esophagus becomes. Plummer-Vinson syndrome is known for causing esophageal webs, iron deficiency anemia, and glossitis, so individuals with Plummer-Vinson also have symptoms of fatigue and an inflamed tongue. On a barium swallow, esophageal webs appear just like Shiatsky's ring, only higher in the esophagus. An upper endoscopy will show the esophageal webs as thin membranes in the lumen that don't occupy the entire circumference. Treatment of esophageal webs is pneumatic dilation, with repeat dilations sometimes needed. With Zenker's diverticulum, the mucosa and submucosa of the esophagus slide through an area of muscle weakness right above the upper esophageal sphincter and form a pouch-like structure outside the lumen of the esophagus. It mostly occurs in elderly males that initially have intermittent oropharyngeal dysphagia, but then develop halitosis or bad breath as solids accumulate in the pouch. They can also have pulmonary aspiration of foods as well as regurgitation. If the diverticulum is big enough, it can be seen and palpated on physical examination. A barium swallow localizes a diverticulum outside of the lumen of the esophagus, and in this situation, an upper endoscopy is not usually recommended due to high risk of perforation. Treatment for Zenker's diverticulum is surgical removal of the diverticulum. With benign esophageal stricture, there is narrowing of the lumen of the esophagus, mostly caused by reflux esophagitis. But other causes can include caustic ingestions, eosinophilic esophagitis, and radiation therapy. Individuals have progressive dysphagia for solids, adenophagia, heartburn, and an unintended weight loss. On a barium swallow, the stricture causes the flow of barium to get obstructed so that it looks like a thin string of contrast is going through the esophagus. On an upper endoscopy, the narrowing of the lumen as well as the esophageal stricture can usually be seen. Treatment in benign esophageal strictures is with pneumatic dilation, and repeated dilations are sometimes needed. If pneumatic dilations don't resolve the symptoms, then a stent may be placed at the site of the stricture. With malignant strictures, there's also narrowing of the lumen, but this time it's caused by the tumor growing inside the esophagus. Like in benign esophageal stricture, symptoms include progressive dysphagia for solids, adenophagia, heartburn, and an unintended weight loss. But, in addition, there may be an upper GI bleed, which can lead to iron deficiency anemia. On the barium swallow, the stricture again can cause the flow of barium to get obstructed, but because tumors are often irregular in shape, the narrowing of the lumen will be irregular as well. It looks a bit like someone has eaten parts of the esophagus. On an upper endoscopy, a tumor mass can be seen within the esophagus, and there are usually ulcers and erosions as well. The biopsy will reveal malignancy and the type of esophageal cancer. Although there are many types of esophageal malignancy, the most common ones are adenocarcinoma due to Barrett's esophagus and squamous cell carcinoma. Treatment is guided by the stage of the esophageal cancer, which is classified into the tumor nodes metastasis or TNM system, which helps to categorize tumors based on their size and growth patterns. Based on the TNM system, esophageal carcinoma has 5 stages, from 0 to 4, 0 meaning only the epithelial wall of the esophagus is infiltrated, and 4 meaning there are distant metastases. Usually, in the first 3 stages of esophageal carcinoma, 0, 1, and 2, the tumor can be surgically or endoscopically resected. However, in stage 3, the tumor is resectable only if it hasn't invaded important structures, such as the aorta, the trachea, or the spine. If it has invaded those structures, then chemoradiation therapy is indicated. Stage 4 is also unresectable, and only chemoradiation is used. Now, as a quick recap, esophageal disorders can be functional, which usually causes intermittent dysphagia for solids and liquids, or mechanical, which usually causes progressive dysphagia for solids. With achalasia, individuals have progressive dysphagia for both solids and liquids, and a high-resolution manometry is the gold standard for diagnosis. Treatment primarily relies on Heller laparoscopic myotomy, pneumatic dilation, and botulinum toxin injections. With diffuse esophageal spasm, individuals present retrosternal chest pain, intermittent dysphagia for both solids and liquids, and again, high-resolution manometry is the gold standard for diagnosis. Treatment in this case mainly relies on calcium channel blockers and nitrates. With esophageal scleroderma, there is no specific treatment, but proton pump inhibitors can prevent acid reflux. With Schiatsky's ring, a thin symmetric mucosal band appears in the lower esophagus, and treatment is with pneumatic dilation. With esophageal webs, there are thin asymmetric membranes that appear in the upper esophagus, and treatment is also pneumatic dilation. With Zenker's diverticulum, individuals have dysphagia and halitosis, and treatment is surgical. With benign esophageal strictures, treatment is pneumatic dilation, whereas with malignant strictures, a biopsy is needed to stage the malignancy using the TNM grading system and to determine the appropriate treatment.
A 33-year-old named Ravi came to the clinic because he has difficulty swallowing food and water over the last 3 months. Physical examination shows significant weight loss, of 7 kilograms or 15 pounds, since his last visit 4 months ago. Esophageal manometry shows incomplete lower esophageal sphincter relaxation in response to swallowing, while barium swallow reveals a dilated esophagus with an area of distal stenosis. At the same time, a 62-year-old man named Frank comes to the clinic because of bad breath, regurgitation of food overnight, and trouble swallowing food. He has had these symptoms for several months. He denies fever, chills, nausea, vomiting, or weight loss. Physical examination shows a mass on the side of his neck. Now, both Ravi and Frank have some form of esophageal disorder. Esophageal disorders can be subdivided into inflammatory esophageal disorders, or esophagitis, which are characterized by an inflammation of the esophageal lining along with dysphagia and odynophagia, functional esophageal disorders, which affect the muscles and nerves that control the motility of the esophagus and cause intermittent dysphagia for solids and liquids, and mechanical esophageal disorders, which are characterized by the blockage of the passageway, and they typically cause progressive dysphagia for solids. Inflammatory esophageal disorders, also known as esophagitis, are characterized by an inflammation of the esophageal lining, and based on the cause, they're also subdivided into several types. First, there's reflux esophagitis, which is associated with the reflux of gastric acid from the stomach back into the esophagus. Alternatively, there's pill-induced esophagitis, where a medication injures the esophagus, thereby causing inflammation and possible upper GI bleeding. It's associated with medications like nonsteroidal anti-inflammatory drugs, or NSAIDs, bisphosphonates, tetracyclines, iron, and potassium chloride. In caustic esophagitis, caustic agents, such as strong acids like vinegar or strong bases like detergents, cause esophageal lesions. The next one is infectious esophagitis, which is most commonly seen in immunocompromised individuals, like those that are HIV positive. The most common causes of HIV-associated esophagitis include Candida albicans, herpes simplex virus 1, and cytomegalovirus. A high-yield fact to remember is that with Candida esophagitis, the upper endoscopy will show patches of adherent, white, or gray pseudomembranes on the underlying mucosa. The histopathology reveals yeast cells and pseudohyphae that invade mucosal cells of the esophagus. Any attempt to remove the pseudomembrane can cause bleeding in the underlying mucosa. With HSV esophagitis, a high-yield fact to remember is that an upper endoscopy will show small vesicles and lesions that look like small punched-out ulcers, while the histopathology reveals eosinophilic intranuclear inclusions in multinuclear squamous cells at the margin of the ulcer. For your exam, you have to know that these inclusions are called Cowdrey type A inclusions. CMV esophagitis features linear ulcers on the upper endoscopy, while histopathology reveals both intranuclear and cytoplasmic inclusions. Finally, we have eosinophilic esophagitis, also called allergic esophagitis, which is characterized by eosinophils that infiltrate into the lining of the esophagus. This happens as a reaction to food allergens, and it can lead to dysphagia and food impaction. Eosinophilic esophagitis is most commonly seen in individuals who have other allergies, and a high-yield fact that's often used as a clue is that their esophagitis will be unresponsive to GERD therapy. During an upper endoscopy, eosinophilic esophagitis is characterized by linear furrows and esophageal rings, which are thin mucosal bands that surround the esophagus. Moving on to functional esophageal conditions, which include achalasia, diffuse esophageal spasm, and scleroderma esophageal dysmotility. Achalasia is when there's impaired esophageal motility and the inability to relax the lower esophageal sphincter. The most common cause of primary achalasia is idiopathic degeneration or damage of the postganglionic inhibitory neurons in the mesenteric or Auerbach plexus of the esophagus. There's also secondary achalasia, which is caused by Trypanosoma cruzi infection that cause Chagas disease, or extraesophageal malignancies. So normally the neurons in the mesenteric plexus release inhibitory neurotransmitters, like nitric oxide and vasoactive intestinal peptide, which relax the lower esophageal sphincter. Eventually, the lack of inhibitory neurotransmitters leads to an increased resting lower esophageal sphincter tone, and this obstruction leads to dilatation of the esophagus. These individuals present with progressive dysphagia for both solids and liquids, regurgitation of undigested food, aspiration, chest pain, heartburn, and weight loss. In addition, they have an increased risk for esophageal squamous cell and adenocarcinoma. For diagnosis, remember for your exams that barium swallow in achalasia reveals dilatation of the esophagus above the obstruction and tapering of the lower part of the esophagus near the lower esophageal sphincter. This is also known as the bird's beak sign. The gold standard for diagnosis is esophageal manometry, which measures the strength and coordination of the esophageal contractions when a person swallows. This measurement is done at multiple levels, including the upper, middle, and lower esophagus, as well as the lower esophageal sphincter. Now, you might be asked to analyze manometry findings on your exams, so let's go over this. Normally, when a person swallows, involuntary contractions of the pharyngeal muscles propel the food into the esophagus. Propulsion of the food bolus is followed by the contraction of the cricopharyngeal muscle, which initiates the peristaltic wave of the esophagus. This contraction is shown as an upward deflection on the upper esophageal manometry. Next, the middle esophageal manometry reflects normal peristalsis of the middle part of the esophagus. Finally, the lower esophageal manometry reveals the decrease in the lower esophageal sphincter that corresponds to its relaxation and the passing of the bolus into the stomach. Now, for your exam, you have to know that individuals with achalasia have normal findings in the upper part of the esophagus, decrease or absence of peristalsis in the middle part of the esophagus, and high pressure in the lower esophageal sphincter. For treatment, the obstruction can be corrected with balloon dilation, or increased tone can be managed with local injection of botulinum toxin. In diffuse esophageal spasm, there's periodic, non-peristaltic contractions that occur simultaneously with each other. In contrast to achalasia, diffuse esophageal spasm is associated with a normal lower esophageal sphincter tone, since the spasms occur in the walls of the esophagus. For your exams, you have to know that these disorganized involuntary esophageal contractions can cause intermittent dysphagia for both solids and liquids, and occasional retrosternal chest pain. It's important to note that the pain can mimic angina, but it's not associated with physical activity and is not relieved by rest. However, this can still resemble unstable angina. Therefore, every person that's suspected of having diffuse esophageal spasm should undergo a complete cardiac workup to rule out any cardiac pathology. If performed at the time of the symptoms, barium swallow will show a corkscrew or rosary bead appearance of the esophagus, but this is not specific to diffuse esophageal spasm. The gold standard for diagnosis is manometry, which shows uncoordinated high-amplitude peristaltic contractions that can appear throughout the esophagus. Finally, first-line medications in the treatment of diffuse esophageal spasm include nitrates and calcium channel blockers. The next disorder is scleroderma, or systemic sclerosis. This is an autoimmune disease where there's fibrosis of the skin and other organs. These include the esophagus, kidneys, heart, lungs, and muscles. On the other hand, CREST syndrome, now called limited cutaneous form of systemic sclerosis, is the less severe form of the disease. CREST stands for calcinosis, which are calcium deposits in soft tissues, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, which is skin tightening, and telangiectasia, or spider veins near the surface of the skin. For your exam, you have to know that in sclerodermal esophageal dysmotility, the smooth muscle in the esophagus atrophies, and as a result, peristaltic contractions in the mid and distal esophagus become ineffective or totally absent. In addition, the lower esophageal sphincter tone is lower than normal, which can lead to gastroesophageal reflux disease and dysphagia. So these individuals can also present with Barrett esophagus, esophageal strictures, or aspiration. The barium swallow can appear normal, but an upper endoscopy with biopsy can show evidence of muscle atrophy and fibrosis. Finally, manometry in these individuals shows reduced esophageal peristalsis in the middle and lower esophagus and decreased pressure in the lower sphincter. Finally, we have mechanical esophageal conditions, which include Schatzki's ring, Plummer-Vinson syndrome, Zenker's diverticulum, esophageal strictures, and obstruction. Schatzki's ring is a thin symmetrical mucosal band, which is most commonly located at the gastroesophageal junction. The exact cause is unknown, but it can be associated with chronic acid reflux. For your exam, you should know that in most cases, individuals have no symptoms, but if the lumen of the esophagus gets too narrowed, individuals can present with intermittent dysphagia for solids. On a barium swallow, Schatzki's ring is seen as a small and regular ridge above the diaphragm that narrows the lumen of the esophagus. The next one is Plummer-Vinson syndrome. The high-yield concept here is that Plummer-Vinson syndrome is known for causing dysphagia, iron deficiency anemia, and esophageal webs. So the unfortunate mnemonic for this disorder is Plummer's die. These individuals can present with intermittent dysphagia to solids, but also glossitis and fatigue due to iron deficiency anemia. The symptoms of dysphagia can improve with the correction of iron deficiency anemia if there are no advanced esophageal webs. With esophageal webs, a thin membrane made of squamous epithelium projects in the lumen of the esophagus. But unlike Schatzki's ring, an esophageal web is mostly found in the upper third of the esophagus, and it does not occupy the entire circumference of the lumen. On a barium swallow, esophageal webs appear just like Schatzki's ring, only higher in the esophagus. Finally, Plummer-Vinson syndrome is associated with an increased risk of squamous cell carcinoma. The next one is Zenker's diverticulum, which is also known as pharyngoesophageal false diverticulum. For your exam, a high-yield fact is the underlying cause of this condition is impaired relaxation of the cricopharyngeal muscle. As a result, pharyngeal muscles contract more forcefully to propel the food to the esophagus, but at the same time, they increase the pressure within the distal pharynx. Ultimately, this leads to herniation of the mucosa and submucosa through an area with muscle weakness, resulting in the formation of a pouch-like structure outside the lumen of the esophagus. The most common location for Zenker's diverticulum is at the Killian's triangle, between the thyropharyngeus and cricopharyngeus muscles. Individuals with cricopharyngeal muscle dysfunction typically complain about difficulty swallowing where the food gets stuck at the throat level, and this is also described as high dysphagia. Other symptoms include coughing, choking, but also halitosis, or bad breath, which occurs when food gets trapped in the diverticulum and rots. Food regurgitation is also a symptom, and it can lead to food aspiration and subsequent pneumonia. Zenker's diverticulum is more common in elderly males, which typically present with a palpable mass on the lateral side of the neck. Finally, the best way to diagnose a Zenker diverticulum is by barium swallow, where the diverticulum fills with contrast medium, and the treatment includes surgical removal of the diverticulum. Moving on to esophageal strictures, which is the narrowing of the esophagus. They can be subdivided into benign or malignant. Benign esophageal strictures are typically caused by reflux esophagitis, eosinophilic esophagitis, or ingestion of caustic agents. And these individuals have symptoms of progressive dysphagia for solids, odonophagia, heartburn, and unintended weight loss. On a barium swallow, the stricture causes the flow of barium to get obstructed, so that it looks like a thin string of contrast going through the esophagus. On the other hand, malignant esophageal strictures are caused by the tumor growing inside the esophagus. Like in benign esophageal stricture, symptoms include progressive dysphagia for solids, odonophagia, heartburn, and unintended weight loss. In addition, these individuals can have upper gastrointestinal bleeding, which can lead to iron deficiency anemia. On a barium swallow, the stricture again causes the flow of barium to get obstructed. But because tumors are often irregular in shape, the narrowing of the lumen will be irregular as well. Finally, for your exam, you have to know that the obstruction of the esophagus, like with malignant obstruction, can cause the same presentation and manometric findings as achalasia, and this condition is called pseudoachalasia. Alright, as a quick recap. Inflammatory esophageal disorders, also known as esophagitis, are characterized by an inflammation of the esophageal lining, and they include reflux esophagitis, pill-induced esophagitis, caustic esophagitis, infectious esophagitis, and eosinophilic esophagitis. Functional esophageal disorders affect the muscles and nerves that control the motility of the esophagus, and they typically cause intermittent dysphagia for solids and liquids. Achalasia is associated with impaired esophageal motility and inability to relax the lower esophageal sphincter, and it's most commonly caused by idiopathic degeneration or damage of the postganglionic inhibitory neurons in the myenteric plexus of the esophagus. In diffuse esophageal spasm, peristaltic contractions of the esophagus are intermittent and uncoordinated, which leads to ineffective peristalsis of the esophagus. With sclerodermal esophageal dysmotility, the smooth muscle in the esophagus atrophies, and as a result, peristaltic contractions in the mid and distal esophagus becomes ineffective or totally absent. Mechanical esophageal disorders are characterized by the blockage of the passageway, and they typically cause progressive dysphagia for solids. Schatzki's ring is a thin, symmetric mucosal band, most commonly located at the gastroesophageal junction, and it can be associated with chronic acid reflux. Plummer-Vinson syndrome is known for causing dysphagia, iron deficiency anemia, and esophageal webs, which are thin asymmetric membranes that don't occupy the entire circumference of the lumen, and appear in the upper third of the esophagus. With Zenker's diverticulum, the mucosa and submucosa of the esophagus slide through an area of muscle weakness right above the upper esophageal sphincter and form a pouch-like structure outside the lumen of the esophagus. Finally, benign esophageal strictures are caused by reflux esophagitis, eosinophilic esophagitis, and ingestion of caustic agents, whereas malignant esophageal strictures are caused by the tumor growing inside the esophagus. Alright, now back to our case. Ravi came to the clinic because he experienced difficulty swallowing food and water over the last 3 months. In other words, he has dysphagia to solids and liquids. Therefore, we can assume it's a functional esophageal disorder. Esophageal manometry showed an incomplete lower sphincter relaxation, while the barium swallow revealed a dilated esophagus with an area of distal stenosis. So this is a classic case of achalasia. On the other hand, Frank came to the clinic because of bad breath, regurgitation of food overnight, and trouble swallowing solids. Since his problem includes only solids, we can assume he has a mechanical esophageal disorder. The bad breath, food regurgitation, and mass on the side of his neck are the key clues here. So in this case, a barium swallow was ordered, which confirmed the diagnosis of Zenker's diverticulum.
Achalasia is an esophageal disorder that makes it difficult for food to pass from the esophagus into the stomach, causing symptoms such as difficulty swallowing, regurgitation of undigested food, and chest pain. With achalasia, esophageal peristalsis is impaired due to progressive degeneration of myenteric neurons, which are neurons of the gastrointestinal tract. Impairment of these neurons prevents food from being effectively moved through the esophagus. It also prevents the lower esophageal sphincter from completely relaxing during swallowing, which stops food from passing, and leads to dilation of the esophagus as food builds up. Most cases of achalasia occur due to an unknown cause, though there may be secondary causes, including damage to myenteric neurons by Trypanosoma cruzi, the organisms responsible for Chagas disease, or extraesophageal malignancies. Now, the most common symptom of achalasia is difficulty swallowing, also known as dysphagia. With achalasia, dysphagia appears slowly and gradually, so some people may compensate by eating more slowly or by lifting the neck or throwing the shoulders back when swallowing to improve emptying of the esophagus. Other symptoms may include regurgitation of undigested food, weight loss, chest pain, and heartburn. Diagnosis of achalasia is based on the individual's symptoms, but tests are needed to confirm the diagnosis. The barium swallow test is a common screening test for achalasia. It involves swallowing a chalky, thick mixture of barium while X-rays are taken. The barium swallow test shows dilation of the esophagus and a narrow region at the end, classically described as a bird's beak appearance. However, the gold standard for diagnosis is esophageal manometry, which measures the strength and coordination of the esophageal contractions when an individual swallows. Manometry typically reveals an absence of peristaltic contractions in the lower esophagus, high pressure in the lower esophageal sphincter at rest, and failure of the lower esophageal sphincter to relax during swallowing. Although an upper endoscopy is not useful to diagnose achalasia, it may be done to rule out esophageal cancer or secondary causes of achalasia. Treatment for achalasia focuses on relieving the symptoms and reducing the pressure of the lower esophageal sphincter so that it no longer poses a barrier to the passage of food. The lower esophageal sphincter can be weakened mechanically by procedures that tear or cut the lower esophageal sphincter muscle, or weakened by medications that decrease pressure in the lower esophageal sphincter. The most effective and long-lasting treatment is Heller laparoscopic myotomy, a surgical intervention where a small cut is made in the lower sphincter to relieve that pressure. Other options include pneumatic dilation of the lower esophageal sphincter and botulinum toxin injections. Medical therapy with calcium channel blockers or sublingual nitrates is a generally ineffective treatment for achalasia, but it can be used in cases where surgery cannot be done, and botulinum toxin injections are not effective. Alright, as a quick recap. Achalasia is an esophageal disorder characterized by impaired esophageal motility and incomplete lower esophageal sphincter relaxation that causes progressive dysphagia, regurgitation of food, and chest pain. The gold standard for diagnosis is esophageal manometry, which shows high pressure in the lower esophageal sphincter, incomplete lower sphincter relaxation, and decreased esophageal peristalsis. Treatment focuses on reducing the pressure of the lower esophageal sphincter, which can be accomplished by procedures that tear or cut the sphincter muscle, or by medications.
Eosinophilic esophagitis, or EOE, is a chronic food allergy-associated digestive disorder in which people have large numbers of eosinophils in the esophagus. Eosinophils are a type of white blood cell that play many roles within the immune system and are involved in allergic reactions. Signs and symptoms of eosinophilic esophagitis can vary quite a bit and are frequently the same as those for gastroesophageal reflux disease, also known as GERD. These symptoms are caused by increased inflammation and swelling within the esophagus and include trouble swallowing, food getting stuck in the throat, nausea, vomiting, poor growth in childhood, weight loss, stomach pain, poor appetite, and malnutrition. The increase in eosinophils in the esophagus can be caused by a number of things, particularly hypersensitivity reactions or changes to the expression of certain genes. The hypersensitivity reactions involved are a form of allergic reaction after exposure to a food or environmental allergen. When certain cells come in contact with the allergen, they signal other cells, most commonly eosinophils, to accumulate and get activated in the esophagus. The first exposure to an allergen may take time to create a response. However, some cells remember that allergen to more quickly react to future exposures. Therefore, the more a person is exposed to allergens which trigger a hypersensitivity reaction, the more eosinophils will be present. Additionally, changes to gene expression appear to play a role in increasing the number of eosinophils in a person with EOE. A primary gene involved in people with EOE is CCL26, which encodes for eotaxin 3. Eotaxin 3 is a protein that triggers increased eosinophil production, and the gene is often overexpressed, meaning it is used to make more proteins than usual in people with eosinophilic esophagitis. When eotaxin 3 makes more proteins, those proteins trigger more eosinophils to be recruited to the esophagus, consequently resulting in the increased number of eosinophils present in people with EOE. Some other genes that are associated with EOE, such as CAPN14, eosinophilic esophagitis can usually be treated by taking a proton pump inhibitor pill to decrease inflammation in the esophagus, as well as avoiding common food allergens such as milk, soy, eggs, wheat, nuts, and fish. If symptoms continue after initial treatments, more intensive treatments may be required. These other treatments include prescription steroids to further reduce inflammation and inserting a feeding tube to provide all meals in a liquid form directly into the stomach to avoid the esophagus coming in contact with any potential allergens. A number of biological agents, especially those that directly target eosinophils or allergic hypersensitivity, are now being developed for the treatment of eosinophilic esophagitis. Eosinophilic esophagitis is a chronic digestive disorder in which there is an increased number of eosinophils in the esophagus. The signs and symptoms often resemble GERD and can vary from difficulty swallowing to failure to thrive in children. The increased eosinophils are typically caused by allergic immune hypersensitivity to food allergens and altered expression of certain genes. After a clinical evaluation, diagnosis is established by an upper endoscopy and related biopsies. Most people can be treated with proton pump inhibitors, dietary treatment, or topical glucocorticoids or steroids. Gastric cancer is when malignant or cancerous cells arise in the stomach. This cancer can appear in any part of the stomach, and it's classified into adenocarcinoma, lymphoma, carcinoid tumor, and leiomyosarcoma, depending on the types of cells it originates from. Adeno means gland, so adenocarcinoma arises from columnar glandular epithelium. Lymphoma arises from lymphocytes. Carcinoid tumor is originated in the G cells of the stomach, and leiomyosarcoma arises from smooth muscle cells from the gastric wall. Gastric cancer is generally considered a poor prognosis cancer because it doesn't cause specific symptoms until later stages. Now, the stomach has 4 regions: the cardia, the fundus, the body, and the pyloric antrum. There's also a pyloric sphincter or valve at the end of the stomach, which closes while eating, keeping food inside the stomach to digest. The gastric wall is made up of 4 layers. From the outside in, there's the adventitia, or serosa, the muscular layer, the submucosa, and the mucosa. The mucosa comes into direct contact with food, and it also has 3 layers of its own. The innermost layer is the epithelial layer, and it absorbs and secretes mucus and digestive enzymes. The middle layer is the lamina propria, and it has blood, lymph vessels, and mucosa-associated lymphoid tissue, or MALT for short, which are nodules of immune cells called lymphocytes, in charge of eliminating pathogens that could pass through the epithelial layer. The outermost layer of the mucosa is the muscularis mucosa, and it's a smooth muscle layer that contracts and helps with the breakdown of food. The epithelial layer dips down below the surface of the stomach lining to form gastric pits, and these pits are contiguous with gastric glands below, which contain various epithelial cell types, each secreting a variety of substances. So, for example, foveolar cells, or surface mucus cells, secrete mucus, which is a mix of water and glycoproteins that coats the stomach epithelial cells. With all of these digestive enzymes and hydrochloric acid floating around, the stomach and duodenal mucosa would get digested if not for this mucus which coats and protects the epithelial cells. Within the glands, particularly in the body and fundus of the stomach, are parietal cells, which secrete hydrochloric acid to help maintain an acidic pH in the stomach. There are also chief cells that secrete pepsinogen to digest proteins. And then there are G cells that secrete gastrin, which has a number of effects, including stimulation of parietal cells to secrete hydrochloric acid. Now, adenocarcinoma is the most common type of gastric cancer, and it originates in the columnar glandular epithelium. It's further divided into 2 subtypes: intestinal, or well-differentiated adenocarcinoma, and diffuse, or undifferentiated adenocarcinoma. Intestinal type is the most common. In most cases, it's caused by the bacteria Helicobacter pylori, or H. pylori for short. H. pylori releases some virulence factors, like CAG-A, that go inside the epithelial cells and cause extensive damage. The immune system detects this damage and causes an inflammatory response within the gastric lining, causing gastritis. As long as H. pylori remains in the stomach, it continues to damage the mucosa, and local inflammation persists, leading to chronic gastritis. When this happens, the normal epithelium of the stomach gets continuously damaged and repaired. Over time, the stomach cells in the epithelium change and start to resemble intestinal epithelium. This is called metaplasia, which is when one type of cells in the body changes to resemble cells in another part of the body. Over time, these metaplastic cells might accumulate mutations in the genes that are in charge of the cell cycle and cell division. Tumor suppressor genes, which normally code for proteins that stop the cell cycle or promote apoptosis, are the cell cycle's very own brake pedal, while proto-oncogenes, which normally code for proteins that promote the cell cycle, are the cell cycle's accelerator pedal. Mutations can occur in both. When this happens, metaplastic cells start dividing uncontrollably, and more mutations accumulate with each division. So eventually, these mutations might make the cells malignant, meaning they gain the ability to invade neighboring tissues and spread to distant sites. This type of adenocarcinoma typically appears on the lesser curvature of the antrum as a large,
irregular ulcer with heaped up edges. Histologically, it's a well-differentiated cancer, meaning they resemble normal intestinal cells. Alternatively, diffuse type of adenocarcinoma can appear in any part of the stomach, and it's mostly related to genetic mutations in the CDH1 gene, a tumor suppressor gene that codes for a membrane adhesion molecule called E-cadherin. Normally, E-cadherin helps epithelial cells stick to one another, and it also transmits signals that control the progression of the cell cycle. But when E-cadherin isn't working properly, cells detach and start dividing uncontrollably. This type of adenocarcinoma has an increased ability to spread and invade adjacent structures, so it's way more aggressive than the intestinal type. Diffuse adenocarcinoma can appear in any part of the stomach, and it can cause gastric linitis or linitis plastica, where the stomach wall grows thick and hard and looks like a leather bottle. This is the result of diffuse adenocarcinoma invading the connective tissue of the submucosa, causing it to become thicker and more rigid. Histologically, there's signet ring cells scattered throughout the connective tissue that look, well, like a signet ring, because the cytoplasm has giant vacuoles that push the nucleus to the edge of the cell. Now, there's other less common types of gastric tumors, like lymphomas, carcinoid tumors, and leiomyosarcomas. Lymphomas arise mostly from lymphocytes found in malt, or mucosa-associated lymphoid tissue. These cells, more specifically B lymphocytes, or B cells, are in charge of recognizing and responding to any pathogen that crosses the epithelial layer. So, a chronic H. pylori infection, for example, can cause excessive B cell proliferation, which makes these cells more prone to having mutations and developing lymphoma. Histologically, it usually appears as diffuse lymphocytes surrounding the normal lymphoid nodules and epithelial cells. Carcinoid tumor arises in neuroendocrine cells like the G cells of the stomach. It's a well-differentiated tumor that usually appears as a protruding mass from the mucosa called a polyp. Although it mainly appears in the stomach, it can also arise in other parts of the digestive tract, like the intestine or the pancreas, which also have G cells. Finally, leiomyosarcoma arises from smooth muscle cells from the gastric wall, and it's extremely rare. Under the microscope, cancerous cells can look like spindle, epithelial, or undifferentiated cells. Complications for gastric adenocarcinoma include metastasis to the peritoneum, to lymph nodes, like the ones around the umbilicus and the left supraclavicular node, or Virchow's node, or to distant organs, most frequently the liver. The bilateral metastases of diffuse adenocarcinoma to the ovaries causes a particular tumor called the Krukenberg tumor, which has abundant signet ring cells. Other complications are paraneoplastic syndromes, which are problems caused by the primary tumor on other organs without necessarily being metastasis. Paraneoplastic syndromes include the Leigh-Strauss sign, which is seborrheic keratosis, or brownish spots all over the skin. It results from the stimulation of keratinocytes by growth factors produced by the gastric cancer cells. Polyarteritis nodosa refers to inflammation and necrosis of multiple medium-sized arteries, including those that supply the kidneys and the heart, so they can eventually lead to kidney failure or myocardial infarction. Now, cancer cells stimulate vascular and inflammatory cells to release tissue factor, which then activates the coagulation cascade. Therefore, there's an increase in blood coagulability that leads to thrombosis, or generation of blood clots. Trousseau syndrome consists of the appearance of migratory thrombosis in the veins. Finally, if gastric cancer grows near the gastroesophageal junction, it can cause a stricture that makes it difficult for foods and liquids to pass through from the esophagus into the stomach, which is called pseudoachalasia syndrome. Generally speaking, risk factors for gastric cancer include a family history of gastric cancer, smoking, alcohol consumption, and being obese. Also, the risk for gastric cancer increases with age. Specific risk factors for the intestinal type of adenocarcinoma include being male, H. pylori infection, having blood type A, a diet rich in nitrates, nitrosamines, highly salted foods, pickled or smoked foods, and conditions such as autoimmune gastritis and pernicious anemia and achlorhydria. Autoimmune gastritis is when the self-immune system attacks the parietal cells, causing inflammation. Pernicious anemia is a condition where there's decreased production of red blood cells due to a deficiency of vitamin B12. And achlorhydria means decreased or lack of gastric acid production. On the other side, there's protective factors to prevent gastric cancer, and these include a high intake of fruits, vegetables, fiber, and folate. Initially, gastric cancer can be asymptomatic. If there are symptoms, they're usually vague, like malaise, loss of appetite, and dyspepsia, which is a burning sensation in the upper part of the abdomen. Once the disease progresses, the main symptoms include epigastric pain, nausea, vomiting, and weight loss. In addition, gastric cancer can ulcerate and bleed. If there's significant blood loss, this can cause anemia. Also, the accumulation of blood in the stomach can cause hematemesis, or vomiting of blood. This can be bright red blood, or have a darker color like coffee grounds when the red blood cells have been broken down by gastric acid. Finally, there could be melena, where the discolored blood can also appear in stool, making it black. Other signs and symptoms include those of paraneoplastic syndromes, Leigh-Treslau's, polyarteritis nodosa, and Trousseau syndrome. Acanthosis nigricans is another sign that could be present, and involves darkening of the skin at the axilla and other skin folds. Sister Mary Joseph sign is a mass around the belly button caused by metastasis and enlargement of the lymph nodes in that area. Trousseau's sign refers to an enlarged, hard Virchow's node, also caused by metastasis. Finally, if gastric cancer grows near the gastroesophageal junction, there might be dysphagia or difficulty swallowing. Diagnosis of gastric cancer is essentially made with endoscopy, which is when a tube with a camera at the end of it is placed into the stomach to directly visualize the tumor and take a biopsy. X-rays with barium contrast of the upper GI tract can be useful to identify complications like ulcers. And finally, abdominal pelvic CT can be used to evaluate if the cancer has spread to nearby organs or lymph nodes in order to determine the stage of the tumor. Treatment depends on the stage. For initial stages, surgery can be performed to treat the cancer. For advanced stages, surgery can only relieve the pain, called palliative surgery. Chemoradiotherapy after surgery is used to increase the chance of survival. Unfortunately, the overall survival rate is very low because gastric cancer is usually diagnosed at very advanced stages. Alright, as a quick recap, gastric cancer is when malignant or cancerous cells arise in the stomach. It's classified into adenocarcinoma, lymphoma, carcinoid tumor, and leiomyosarcoma, although the first one accounts for the majority of cases. Complications like metastasis and paraneoplastic syndromes like Leigh-Treslau's, polyarteritis nodosa, and Trousseau syndrome. Risk factors include family history of gastric cancer, smoking, alcohol consumption, and being obese. H. pylori infection is the most important risk factor for the intestinal type of adenocarcinoma. Protective factors include a high intake of fruits, vegetables, fiber, and folate. Early symptoms include malaise, loss of appetite, and dyspepsia. Epigastric pain, nausea, vomiting, and weight loss are later symptoms. Diagnosis is made with endoscopy and biopsy. X-rays with barium contrast of the upper GI and abdominal pelvic CT are used for further evaluation. The treatment depends on the stage. For initial stages, surgery can be sufficient. For advanced stages, there's palliative surgery combined with chemoradiotherapy.
The gastrointestinal system depends on the coordination of the sympathetic and parasympathetic nervous systems, as well as pacemaker cells and neurons within the walls of the stomach and intestine, and the smooth muscle in the gastrointestinal walls. If any part is disturbed, then it can lead to gastroparesis, which is delayed gastric emptying in the absence of a mechanical obstruction. Gastroparesis is usually idiopathic, but it's associated with a number of diseases like diabetes mellitus, hypothyroidism, neurological conditions like Parkinson's disease, viral infections, or even an autoimmune attack. There are also iatrogenic causes like inadvertent vagal nerve damage during surgery, or can be due to medications like opioids, alpha-2 adrenergic agonists like clonidine, tricyclic antidepressants like amitriptyline, and anticholinergics like atropine. Individuals with gastroparesis can have symptoms like nausea, vomiting, upper abdominal pain, early satiety, bloating, and in severe cases, unintentional weight loss. On physical examination, there's usually epigastric distension or tenderness in the upper abdomen, but without guarding or rigidity. When gastroparesis is suspected, individuals should undergo an upper endoscopy to make sure that there's no mechanical obstruction. Because an upper endoscopy might not always reveal a mechanical obstruction, after the upper endoscopy, an abdominal CT or magnetic resonance interrography can be done to confirm that there's no mechanical obstruction. Now, to establish the diagnosis of gastroparesis, a scintigraphic gastric emptying test should be done. For this test, medications that affect the gastric motility should be stopped at least 48 hours before the test is done. In addition, individuals with diabetes mellitus should have their glucose blood levels measured before the test and if they're hyperglycemic. Then this should be treated before the test is done as well. For the test to be accurate, glucose levels should be lower than 275 milligrams per deciliter. Then the individual usually ingests a low-fat egg white meal and a tasteless radioactive material, usually technetium, which shows up on the scintigraphy. Imaging is performed immediately after the ingestion and then again at 2 and 4 hours after ingestion. Delayed gastric emptying is defined as the retention of more than 60% of the gastric content at 2 hours and more than 10% of the gastric contents at 4 hours. Based on the values at 4 hours, delayed gastric emptying is considered mild if 10 to 15% of the gastric content is retained, moderate if 15 to 35% of the gastric content is retained, or severe if more than 35% of the gastric content is retained. Once the diagnosis of gastroparesis is established, it's important to investigate the underlying cause. Lab tests include hemoglobin to check for anemia, especially if malignancy is suspected, fasting plasma glucose, serum total protein, albumin to assess for malnutrition in individuals that have unintentional weight loss, TSH to check for hypothyroidism, and an anti-nuclear antibody or ANA to search for an autoimmune disease. In individuals with diabetes mellitus, HbA1c is taken to assess glycemic control. If the individual has a history of smoking, then ANNA1 or anti-HU antibodies are also obtained, because gastroparesis might also appear as a paraneoplastic syndrome, particularly with lung cancer. Next, it's important to differentiate a myopathic process, a disorder of the skeletal muscles, like scleroderma, from a neuropathic process, a disorder of the nervous system, like diabetes. That can be done with gastroduodenal manometry, which is where a pressure-sensitive tube is endoscopically placed through the nose and into the small intestine for 1 to 2 hours. The tube senses pressure from muscle contractions. With a myopathic process, the muscle contractions are low amplitude, whereas with a neuropathic process, the muscle contractions are usually of normal amplitude. Treatment of gastroparesis is usually based on dietary modifications and avoiding medications that delay gastric emptying. First of all, individuals with diabetes mellitus should try to maintain tight glycemic control, because acute hyperglycemia can delay gastric emptying. These individuals should also avoid incretin-based therapies, like pramlintide and glucagon-like peptide 1 analogs, because they can delay gastric emptying as well. Dietary modifications that can help are eating smaller, more frequent meals, up to 5 times per day, that are low in fat and contain soluble fiber, like black beans or broccoli. That's because both fat and insoluble fibers, like oats, delay gastric emptying. Carbonated drinks, alcohol, and smoking should also be avoided for the same reason. Individuals with mild gastroparesis are told to focus on good hydration and are often given vitamin supplementation. If the individual is unable to tolerate solids, then vitamins are added to liquid meals. If dietary modifications aren't enough to control the symptoms of gastroparesis, then medication therapy is used. Prokinetic medications like metoclopramide is first-line therapy with gastroparesis because it improves gastric emptying by increasing antral contractions of the stomach and by decreasing gastric fundus relaxation after a meal. If the individual doesn't respond to metoclopramide, then another prokinetic medication, domperidone, might be used. Before and during treatment with domperidone, electrocardiograms must be done, because domperidone increases the risk for cardiac arrhythmias. If the individual doesn't respond to prokinetic medication, then macrolide antibiotics, like erythromycin, can be given because they induce high-amplitude gastric contractions that increase gastric emptying. It's important to keep in mind, though, that erythromycin can induce tachyphylaxis, meaning that the more it's administered, the less effective it'll be. Now, another condition that causes symptoms similar to gastroparesis is cyclic vomiting syndrome. Cyclic vomiting syndrome is an idiopathic disorder where an individual has episodes of recurrent vomiting alternating with periods of normal health. The pattern of vomiting episodes is different for every individual, but in general, vomiting starts early in the morning and is accompanied by lethargy, abdominal pain, and anorexia. In adults, the episodes of vomiting usually last up to 6 days, followed by a few months of normal health. In children, vomiting episodes are more irregular and can happen every few weeks. Cyclic vomiting syndromes associated with migraine headaches, as well as autonomic disorders like having an elevated sympathetic tone, endocrine disorders that cause overstimulation of the hypothalamic pituitary adrenal axis, various food allergies, and is linked to chronic cannabis use. Cyclic vomiting syndrome is a diagnosis of exclusion that requires excluding other causes of vomiting, like toxic etiologies or bowel disorders. Treatment includes supportive measures, like preventing dehydration with intravenous fluids, antiemetics like dolasetron, and using sedatives like lorazepam. Alright, as a quick recap, gastroparesis is a functional syndrome of delayed gastric emptying that causes symptoms like nausea, vomiting, abdominal pain, early satiety, and bloating. An upper endoscopy, as well as an abdominal CT or an MRI, are done to rule out a mechanical obstruction. A scintigraphic gastric emptying test is done to confirm the diagnosis of gastroparesis, and after 4 hours it's considered mild if 10 to 15% of the gastric content is in the stomach, moderate if 15 to 35% is left, and severe if more than 35% is left. To find the cause of gastroparesis, lab work includes hemoglobin, fasting plasma glucose, serum protein, albumin, TSH, ANA, HbA1c, ANNA1, and anti-Hu. A duodenal manometry might be performed to differentiate a myopathic cause from a neuropathic cause of gastroparesis. Treatment includes dietary modifications, avoiding medication that decreases gastric emptying, hydration, and nutrition. And if the symptoms are not controlled with dietary modifications, medications like metoclopramide, domperidone, and erythromycin are used. On the differential is cyclic vomiting syndrome, which causes recurrent episodes of vomiting that alternate with periods of normal health, and is associated with migraine headaches and abdominal pain. Cyclic vomiting syndrome is a diagnosis of exclusion, and treatment includes supportive measures like intravenous fluids, antiemetics, and sedatives. Peptic refers to the stomach, and an ulcer is a sore or break in a membrane. Describes having one or more sores in the stomach, called gastric ulcers, or duodenum, called duodenal ulcers, which are actually more common. Normally, the inner wall of the entire gastrointestinal tract is lined with mucosa, which consists of 3 cell layers. The innermost layer is the epithelial layer, and it absorbs and secretes mucus and digestive enzymes. The middle layer is the lamina propria, and it has blood and lymph vessels. The outermost layer of the mucosa is the muscularis mucosa, and it's a layer of smooth muscle that contracts and helps with the breakdown of food. Now, in the stomach, there are 4 regions: the cardia, the fundus, the body, and the pyloric antrum. There's also a pyloric sphincter, or valve, at the end of the stomach, which closes while eating, keeping food inside for the stomach to digest. The epithelial layer in different parts of the stomach contains different proportions of gastric glands, which secrete a variety of substances. Having said that, the cardia has mostly foveolar cells that secrete mucus, which is mostly made up of water and glycoproteins. The fundus and the body have mostly parietal cells that secrete hydrochloric acid and chief cells that secrete pepsinogen, which is an enzyme that digests protein. Finally, the antrum has mostly G cells that secrete gastrin in response to food entering the stomach. These G cells are also found in the duodenum and the pancreas, which is an accessory gland of the gastrointestinal tract. Now, gastrin stimulates the parietal cells to secrete hydrochloric acid, and also stimulates the growth of glands in the epithelial layer. In addition, the duodenum has Brunner glands, which secrete mucus rich in bicarbonate ions into the lumen. With all the digestive enzymes and hydrochloric acid floating around, the stomach and duodenal mucosa would get digested if not for the mucus coating the walls and bicarbonate ions secreted by the duodenum, which neutralizes the acid. Since the stomach walls are constantly exposed to the acid, they have a thicker mucus layer when compared to the duodenum, which is only momentarily exposed to the acid. In addition, the blood flowing to the stomach and duodenum brings even more bicarbonate, which again helps neutralize the hydrochloric acid. Finally, small signaling molecules called prostaglandins get secreted in the stomach and duodenum, and they stimulate mucus and bicarbonate secretion, as well as vasodilation of the nearby blood vessels, which allows more blood to flow to the area. And this promotes new epithelial cell growth, and also inhibits acid secretion. The main cause of gastric and duodenal ulcers is infection with H. pylori bacteria, especially in low-income countries and settings. H. pylori are gram-negative bacteria that colonize the gastric mucosa and release adhesins that help them adhere to gastric foveolar cells, as well as proteases that cause damage to mucosal cells. The majority of individuals with H. pylori don't develop any problems, but sometimes it causes a patchy pattern of damage that starts in the antrum, and then spreads to the rest of the stomach and eventually into the duodenum. Over time, the damage erodes deeper and deeper into the mucosa, eventually causing ulcers. Another cause of gastric ulcers, and less so duodenal ulcers, are non-steroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen. NSAIDs inhibit the enzyme cyclooxygenase, which is involved in the synthesis of inflammatory prostaglandins. Reducing the level of prostaglandins over a prolonged period of time, though, leaves the gastric mucosa susceptible to damage, and over time ulcers can start to develop. A rare cause of peptic ulcer disease is Zollinger-Ellison syndrome, which is due to a tumor called a gastrinoma. A gastrinoma is a neuroendocrine tumor that's typically located in the duodenal wall or pancreas, and secretes abnormal amounts of gastrin. Excess gastrin stimulates parietal cells to release excess hydrochloric acid, which overwhelms normal defense mechanisms and allows ulcers to develop in the first portion of the duodenum, or even in the distal duodenum or jejunum. Peptic ulcers that result from any of these mucosa-damaging mechanisms are usually small, round, punched-out holes in the mucosa. The ulcers usually have a clean base, because the hydrochloric acid secretions and the constant churning is a bit like a dishwasher, actually keeping debris out of the ulcer. Typically, beneath the base is a layer of scar tissue and blood vessels, and occasionally the ulcers can bleed if the erosion goes deep. Gastric ulcers typically form in the lesser curvature of the antrum. Duodenal ulcers, on the other hand, usually develop right after the pyloric sphincter, and there's usually Brunner gland hypertrophy, which is a consequence of the body trying to produce more mucus to protect the damaged area. Very deep ulcers can erode into underlying blood vessels, and can cause bleeding, which is a problem that's extremely dangerous when there's a nearby artery. That's because hemorrhage into the gastrointestinal tract can happen, and this rapid loss of blood can ultimately lead to shock. Two well-known dangerous spots are when there's a gastric ulcer on the lesser curvature of the stomach eroding into the left gastric artery, and a duodenal ulcer on the posterior wall of the duodenum eroding into the gastroduodenal artery. Another complication is perforation, which is when an ulcer erodes all the way through the wall of the stomach or duodenum, allowing gastrointestinal contents like undigested food and gastric secretions to get into the peritoneal space, which is usually sterile. Perforation is a well-known complication of duodenal ulcers on the anterior wall of the duodenum. When they perforate, air starts to collect under the diaphragm, irritating the phrenic nerve and sending referred pain up to the shoulder. Finally, and very rarely, long-standing duodenal ulcers near the pyloric sphincter can sometimes have so much edema or scarring that they obstruct the normal passage of gastric contents into the intestines, resulting in gastric outlet obstruction. And this can quickly lead to nausea or vomiting since the food literally can't get by. The main symptom of gastric and duodenal ulcers is epigastric pain, which is an aching or burning in the upper abdomen. Other symptoms are bloating, belching, and vomiting. Classically, gastric ulcer pain increases while eating a meal due to the physical presence of the food, as well as the hydrochloric acid production stimulated by the process of eating. On the other hand, duodenal ulcer pain decreases while eating a meal. This might be why gastric ulcers are associated with weight loss, while duodenal ulcers are associated with weight gain. Peptic ulcers can be diagnosed with upper endoscopy, which is when a tube is snaked through the esophagus, into the stomach, and then the proximal duodenum in order to see the ulcer itself. Usually during the procedure, a biopsy is done to make sure that there are no signs of malignant cells and to see if there are signs of an H. pylori infection. Treatment of peptic ulcers depends on the underlying cause. If there's an H. pylori infection, it's usually cured with a combination of antibiotics and acid-lowering medications, specifically proton pump inhibitors. Substances that can worsen peptic ulcers include NSAIDs, as well as alcohol, tobacco, and caffeine, so it's best to stop using all of those as soon as possible. And in really extreme cases, surgery might be needed. Alright, as a quick recap. Peptic ulcer disease is when a defect develops in the mucous membrane of the stomach or duodenum, and this causes epigastric pain. Occasionally, they can cause complications like bleeding, perforation, and obstruction. In a lot of cases, they're caused by an H. pylori infection, or the use of NSAIDs. Everyone who's ever had a pimple has had an abscess. Even though they're tiny, they're still abscesses. An abscess forms when normal tissue, like the gingiva or gums in teeth for example, is split apart and that new space is invaded by nearby pathogens, like bacteria. In a healthy mouth, normal or commensal bacteria thrive, but don't cause disease. However, any cut or break in the mucosa is an invitation for bacteria to dive in and multiply, causing an infection. When that happens, the immune system typically responds and a battle ensues, with the result being pus, a mixture of bacteria, immune cells, and dead tissue. So, in response to an injury, cells release small chemicals called cytokines, like tumor necrosis factor, interleukin 1, interleukin 6, interleukin 8, and interleukin 17, and these attract nearby immune cells. It's kind of like yelling for help and being heard by the nearby police. In addition, the cytokines also dilate nearby capillaries and make them leaky, which brings more blood to the site, and allows immune cells that do show up to easily slip out of the blood and into the tissue. The first immune cells at the scene are neutrophils, and they release chemicals and enzymes that kill themselves and the bacteria they swallow up, creating a pool of dead bacteria and cells. This is a specific type of acute inflammatory response called suppurative inflammation, which simply means that pus is created in the process. From a macroscopic view, this is sometimes referred to as a liquefactive necrosis, because the area of dead tissue turns to liquid. Initially, the dead tissue is intermixed with healthy tissue, but over time it can coalesce into a single area. And around this pool of pus, a wall of fibrinogen starts to harden into a barrier. Occasionally, sheets of fibrin form septations, creating loculations or pockets of pus within the abscess itself, kind of like an abscess within an abscess. Even though the pus is largely dead material, there are still plenty of live bacteria within the pus, which makes it highly infectious if it gets spread from one place to another. Now, there are a few different types of dental abscesses. The first one is called a periapical abscess, and it's found at the apical foramen of the tooth. A periapical abscess starts when bacteria gains entry into the dental pulp of the tooth through an opening caused by dental caries or from trauma. The inflammation then spreads and causes necrosis, or tissue death, throughout the entire length of the dental pulp. And if it goes on without treatment, like a root canal, then the infection ultimately reaches the apical foramen of the tooth. Subsequently, the infection reaches the periapical tissues, and at that point it's considered apical periodontitis, which is inflammation of the periapical tissues which secure the tooth in its socket. The infection usually develops into an abscess as the pus coalesces, and it can involve nearby structures like the alveolar bone and adjacent teeth. Sometimes periapical abscesses become quiescent, meaning that they don't grow much, but the bacteria remain alive within the abscess cavity. In that situation, it's called chronic inflammation, and it's where a periapical granuloma forms from this walled-off area. In fact, technically, the term granuloma is a misnomer in this case, since these lesions don't look like normal granulomas under a microscope. During this stage, where there's a stalemate between the infection and the immune system, if the infection gains the upper hand, then it's called an acute apical abscess. Another type of dental abscess is a periodontal abscess, and that involves both the periodontal structures and the gingiva. Typically, a periodontal abscess happens when there's a pre-existing periodontal pocket, perhaps from a deep plaque collection or from a medical procedure. Bacteria get into the periodontal pocket and multiply, leading to an infection and an abscess. Next, there's the gingival abscess, which is where the abscess only involves the gingiva next to the bone, called the marginal or inner dental gingiva, while sparing the periodontal structures. This usually happens when food, plaque, or another foreign object gets stuck in the gingival sulcus, providing a protected place for bacterial growth. Finally, there's a pericorneal abscess, and this happens when the tooth does not erupt completely, leaving a flap of gingival tissue over the top of the crown. When food or another foreign object gets deeply trapped between the flap of gingival tissue and the top of the tooth, an abscess can form. Generally speaking, dental abscesses contain a mix of different bacteria. Some are facultative anaerobes, which means that the bacteria prefer to make energy using oxygen, but can also survive without oxygen, like the Streptococcus aeruginosus group and the viridans group of Streptococci. Others are obligate anaerobes, which means that the bacteria thrive only in the absence of oxygen, like Fusobacterium and Prevotella groups. Symptoms of dental abscesses mainly include local pain and swelling, as well as generalized symptoms like fever and malaise. Dental abscesses can cause affected teeth to loosen, and they can sometimes create a fistula to the surface, where the tissue overlaying the abscess breaks down, allowing it to drain out by itself. This can either be within the mouth or out through another surface, like the cheek. The abscesses can also erode into nearby structures, like the nasal sinuses, causing sinusitis, as well as the floor of the mouth or even into the neck. Diagnosing a dental abscess is usually done by feeling for areas of tenderness and fluctuance. And imaging studies like X-rays or a CT scan can be done to determine the exact location and size. Generally speaking, infections are treated with antibiotics, but in order for antibiotics to work, they need to first reach the bacteria, and that's usually done through the bloodstream. Since abscesses do not have blood vessels inside of them, the antibiotics can only diffuse into an abscess, and that's not very effective, especially when dealing with a large abscess. You could imagine it getting to the bacteria close to the edges, but there's no way it's getting to the bacteria in the middle. That's why the most important treatment for an abscess is incision and drainage. In other words, cutting it open and removing the pus. This is typically followed by frequent saltwater rinses, pain-relieving medications, and regular checkups. For a periapical abscess, a root canal treatment or extraction has to be performed on the offending tooth to get rid of the infection that cannot be reached by an incision and drainage or antibiotic treatment. Sometimes antibiotics are used even after drainage to make sure that there are no additional bacteria lingering around. Alright, as a quick recap. Dental abscesses are a mix of immune cells, pathogens like bacteria like Viridans group Streptococcus, and dead tissue. Common types include periapical, periodontal, gingival, and paracoronal abscesses. Because there's no blood supply to the middle of an abscess to deliver antibiotics, it usually needs to be cut open so that the pus can drain out. For periapical abscesses, a root canal treatment or extraction has to be performed on the offending tooth. Dental caries disease, also called tooth decay, refers to demineralization or weakening of the teeth. And the end result of caries disease is a caries lesion. An advanced caries lesion can progress to the point where the tooth surface forms a cavitation, or a hole, which is the physical evidence of tooth breakdown. Let's start by building a model of a tooth and its surrounding structures. In the mouth, the bone beneath the bottom row of teeth is the mandible, and the bone above the top row of teeth is the maxilla. Both bones have an alveolus, or socket, for each tooth. The socket is lined on the inside by a periodontal ligament. Protecting the alveolus on the outside is a layer of soft, supportive tissue called the gingiva, or gums, that sits on the top of the bone and covers the root surface from the bone to the cemento-enamel junction, where the cementum and the enamel come together. The tooth itself can be roughly divided into a few parts. The first part is the root, and it sits within the alveolus. The root is covered by cementum, which is a bone-like substance that the periodontal ligament's fiber is attached to. Next, there's the neck, which is the transition between the root portion covered by bone and the crown. The crown is the visible part of the tooth that protrudes from the gingiva, and it's covered in enamel, which has such a high mineral content that it's the hardest substance in the human body. When the teeth are developing, enamel is made before the tooth erupts into the mouth, by a group of cells called the amyloblasts, that die once the tooth erupts, meaning that the teeth lose the ability to make more enamel forever. Now let's fill the tooth in from the inside out. Blood vessels and nerves come from the jawbones, and enter the center of the root through a narrow passage, called the apical foramen. From there they enter the soft center of the tooth, called the pulp, where they provide nutrition and sensation. The outer wall of the pulp has odontoblasts, which are cells that secrete a bone-like substance called dentin, which is filled with proteins and minerals. The odontoblasts have long processes, or arms, that lay within tiny tubules in the dentin, kind of like an octopus sticking its arms through a block of cement. These tubules are important for sensory nerves as well, which use them to travel through the dentin from the pulp to the dentin-enamel junction. Finally, there's saliva, which is secreted from several glands in the mouth. Saliva has bicarbonate ions, which helps to neutralize acid in the mouth, as well as glycoproteins like mucin that thickens the saliva. Saliva also has calcium and phosphate, which serve as replacement minerals to help remineralize the tooth surface. So when it comes to dental caries, there's a tug-of-war between the pathogenic factors that promote demineralization of the tooth and protective factors that promote remineralization of the tooth. Normally, there's a layer called the pellicle that covers the tooth, and bacteria in the mouth, like Viridans group Streptococcus, settle on that pellicle layer. These bacteria are called early colonizers, and they attach to the surfaces using bacterial surface proteins called adhesins. Because they're on the pellicle of the teeth, these bacteria come into contact with sucrose, which is a sugar found in various foods and drinks, including table sugar. Sucrose has a glucose molecule bound to a fructose molecule. So the bacteria use an enzyme called glucosyltransferase to cut the bond between them, and use the fructose for energy and add glucose to a growing chain of glucose molecules called the glucan. Glucans allow the bacteria to attach firmly to the surface of the tooth and form dental plaque, which is a sticky collection of bacteria, proteins from saliva, and dead cells from the lining of the mouth. Individual bacteria multiply and form a lot of small microcolonies that coalesce, which creates a layer of dental plaque, which is a type of biofilm. Compared to a microcolony, the bacteria in a biofilm communicate with each other via chemical signaling, and together they create a complex system where some bacteria work on tunneling between the microcolonies and to the surface in order to bring in a steady supply of food. As an analogy, if bacteria were ants, then a microcolony would be a tiny group of ants, each doing its own thing, whereas a biofilm would be an ant farm with complex tunnels and rooms, and each ant carrying out a specialized task. So typically, dental plaque can form on the surface of teeth, but if the pH of the local environment around the tooth surface remains above about 5.5, enamel will not demineralize. One factor that tips the balance towards caries progression is having less bicarbonate-rich saliva, which can result from conditions like Sjogren's syndrome, radiation treatment for cancer, gastric reflux, or as a side effect of a medication or recreational drugs. A key factor that contributes to tooth demineralization is sugar. Some bacteria ferment sucrose, and that produces lactic acid as a byproduct. In addition, acidic foods and drinks can also cause the pH in the mouth to lower. So a drink that has lots of sugar and lots of acid, like soda, which has a pH of around 3, can damage the teeth in two ways. The bacterial population in the mouth is diverse, and if the pH in the mouth starts to decrease, it alters the balance of power. Bacteria that thrive in a low pH, like mutant streptococci and lactobacillus, start to dominate. As dental plaque grows thicker, the amount of oxygen near the enamel surface starts to fall. That makes the environment on the enamel surface favorable for facultative anaerobic bacteria, which can metabolize sugars with and without oxygen present. If sucrose is metabolized anaerobically, or without oxygen, lactic acid starts to build up, and it can quickly lower the pH on the enamel surface to below 5.5. Once the environment becomes that acidic, calcium and phosphate in the enamel start to dissolve into the fluid-filled diffusion channels between the enamel crystals, and that starts the process of demineralization. Every time sugar enters the mouth, the bacteria are able to produce more acid, and this destruction in the subsurface continues until the surface gets so thin that it collapses, like walking on thin ice. Intact enamel keeps bacteria out of the dentin because they do not fit through the enamel diffusion channels. However, if demineralization is allowed to continue, the enamel surface will cavitate to expose the dentin, which will allow bacteria to enter the dentin. Once bacteria are in the dentin, it's called infected dentin, and usually requires a restoration or filling. If destruction continues into the dentin layer, then the caries lesion enlarges towards the pulp. Eventually, the bacteria penetrate into the pulp, causing irritation and damage to the nerves. That's the stage when individuals usually experience pain, although pain can also happen when the caries lesion involves the dentin layer, since sensory nerve fibers travel through tubules in the dentin. Eventually, bacteria travel down into the root canal space and fill the entire inside of the tooth. It's worth mentioning that formation of a caries lesion doesn't have to start with the enamel of the crown. If the gingiva recedes or plaque forms between the gingiva and the root, bacteria and acids have direct access to the cementum, which is much softer than enamel and dissolves more quickly. The demineralization of cementum and dentin can happen in a pH range of 6.2 to 6.8. Symptoms of dental caries include tooth pain and sensitivity, especially when chewing or drinking something that's cold or hot, or sweet. If the process continues, it can eventually lead to a root canal procedure, or even losing a tooth. Diagnosis is usually made based on symptoms, and looking for areas of discoloration or roughness, tenderness or inflammation in the mouth, as well as using dental radiographs. It's always ideal to prevent a caries lesion from forming in the first place, and it starts with a risk assessment for identifying individuals at high risk of caries. That includes individuals that have had a prior or current caries lesion, have problems with saliva production, have specific abnormal levels of acid-forming bacteria, like mutant streptococci and lactobacillus in their mouths, and those that have poor dietary habits, like frequent snacking as well as a high-sugar diet. So treatment of dental caries disease depends on the level of risk. More specifically, reducing the pathogenic risk factors, like antibacterial rinses to get rid of bacteria, and increasing protective factors like products that mimic saliva. In addition, brushing and flossing are useful because they physically remove dental plaque, as well as deliver fluoride to the teeth to help with remineralization. Products that have fluoride can help remineralize spots where enamel has lost its hard minerals. If the enamel surface is intact, then the caries lesion can be treated without drilling a tooth, and instead you can use chemical remineralization. Once the enamel surface is fully cavitated to the dentin, now the bacteria have a pathway to enter the dentin, and it might be necessary to remove the infected dentinal tissue and replace it with a dental filling, which allows the tooth to chew. If the infection is so large that the entire top of the tooth needs to be removed, a dental crown can be used to replace it. Ultimately, these restorative treatments are useful, but they alone don't resolve the underlying cause of the caries lesion, and can't prevent new caries lesions from forming. Alright, as a quick recap. Dental caries lesions are the end result of the dental caries disease process. Dental caries lesions typically form in an environment where there are lots of sugars in the mouth and a pH below 5.5 for enamel and below 6.2 to 6.8 for cementum and dentin. That environment favors bacteria like mutant streptococci and lactobacillus, which demineralize enamel and the dentin beneath it, and if untreated it can eventually result in a cavitated caries lesion. Diagnosis is done by visual inspection and radiographic imaging, and treatment and prevention includes stopping demineralization and promoting remineralization, as well as reducing levels of harmful bacteria and restoring the surface of the tooth, if needed. With gingivitis, gingiva refers to the gums, and itis refers to inflammation. So, gingivitis is inflammation of the gums. With periodontitis, peri means around, and odon refers to the tooth, so it's inflammation and destruction of the supporting structures around the teeth. Broadly speaking, the two are on a spectrum, starting with simple gingivitis on one end, and if the process doesn't get treated, it can develop into more severe disease, periodontitis, which is on the other end of the spectrum. Let's start by building a model of a tooth and its surrounding structures. In the mouth, the bone beneath the bottom row of teeth is the mandible, and the bone above the top row of teeth is the maxilla. Both bones have an alveolus, or socket, for each tooth. The socket's lined on the inside by a periodontal ligament. Protecting the alveolus on the outside is a layer of soft, supportive tissue called the gingiva, or gums, that sits on the top of the bone. The tooth itself can be roughly divided into two parts. The first part is the root, and it sits within the alveolus. The root is covered by a bone-like substance called cementum, and that's what the periodontal ligament's fiber is attached to. Next, there's a short zone called the neck, which is a transition between the root and the crown. The crown is the visible part of the tooth that protrudes from the gingiva, and it's covered in enamel. Enamel has such a high mineral content that it's the hardest substance in the human body. The portion of gingiva that sticks up and is not anchored to the tooth is sometimes called the free gingiva, and the space between the free gingiva and the crown is called the gingival crevice, or gingival sulcus. A watery substance called gingival crevicular fluid flows into the space in small amounts. Gingival crevicular fluid contains various immune proteins in cells like neutrophils, complement proteins, and antibodies. Within the mouth, there are a bunch of bacterial organisms. In a healthy mouth, there's a balance of commensal bacteria that compete with each other, and they're all kept in check by those immune factors. Gingivitis and periodontitis represent a state of imbalance, or dysbiosis. This is when there's a relative increase in pathogenic bacteria, either because of a lack of competition with other commensal bacteria, or because of an ineffective immune response in the mouth. The pathogenic bacteria form dental plaque, which is a sticky collection of bacteria, proteins from saliva, and dead cells from the lining of the mouth. Individual bacteria multiply and form a lot of small microcolonies that coalesce, creating a layer of dental plaque, which is a type of biofilm. Compared to a microcolony, the bacteria in a biofilm communicate with each other via chemical signaling, and together they create a complex system where some bacteria work on tunneling between the microcolonies and to the surface in order to bring in a steady supply of food. As an analogy, if bacteria were ants, then a microcolony would be a tiny group of ants, each doing its own thing, whereas a biofilm would be an ant farm with complex tunnels and rooms, with each ant carrying out a specialized task. Some tooth surfaces, like the portion of the tooth just outside the gingiva, are hard to brush dental plaque away from. If dental plaque above the gingiva keeps building, the bacteria within that biofilm can invade beneath the gingiva, where it becomes really difficult to reach with brushing. Eventually, it can form a hard mass, called a dental calculus. Dental calculus creates a nice space for bacterial plaque formation, because it's hard to remove. And from there, bacteria can enter the gingival sulcus and cause gingival inflammation, or gingivitis. Damaged gingival cells release inflammatory signals that recruit neutrophils to the area, and those neutrophils can release harmful chemicals that kill bacteria, as well as damage the nearby tissue. Fortunately, simple gingivitis is a reversible condition, and the damaged tissue can heal over time as long as the infection is stopped and treated. In periodontitis, the process of dysbiosis is often more extreme, with even more disease-causing bacteria flourishing in the mouth. One classic hypothesis suggests that the first step in periodontitis is the presence of the so-called orange complex of bacteria, which includes gram-negative anaerobic bacteria like Fusobacterium nucleatum and Prevotella intermedia. Once these orange complex bacteria are established, the next step is the presence of the so-called red complex of bacteria, which includes Tannarella forsythia, Treponema denticola, and its most notorious member, Porphyromonas gingivalis, or P. gingivalis for short. Another line of thinking suggests that rather than these red complex bacteria being the specific culprits, it's the overall change in the bacterial community that these bacteria trigger that tips the scale toward periodontitis. Either way, the pathogenic bacteria within the subgingival dental plaque create a periodontal pocket and damage gingival cells in the process. Local mast cells and nerves release chemicals like histamine and substance P, which cause dilation of local blood vessels, resulting in swelling of the gingiva. Damaged gingival cells release additional cytokines like interleukin-1, which brings more immune cells to the area, like neutrophils and macrophages. The body's immune response causes even more damage to the gingiva and periodontal ligament, ultimately loosening the tooth. That one notorious bacteria, P. gingivalis, is also known for impairing immune cells from effectively killing bacteria. This helps other pathogenic bacteria to overgrow as well, kind of like a thief that destroys the police station and allows other thieves to flourish in a city. The immune response also delivers more blood flow to the damaged tissue, which provides more nutrients for the bacteria. Together, the bacteria and immune response end up in a positive feedback loop where the expanding infection causes an increased immune response, which doesn't destroy the bacteria but provides the bacteria with more fuel to grow. The immune response also activates osteoclasts in the bone, which start to dissolve the bone supporting the tooth, loosening it even more. Symptoms of gingivitis typically include redness, swelling, and bleeding, especially after brushing or flossing. Some people, though, experience no symptoms, especially in the early stages of infection. Severe disease that progresses to periodontitis can result in tooth loss. Diagnosis of gingivitis and periodontitis are usually made by looking for swollen or bleeding gums, as well as probing of each gingival sulcus to determine how deep it is, and x-rays to evaluate the bone level. With inflammation and destruction, the sulcus becomes deeper as the periodontal pocket expands. Treatment depends on how severe the infection is. Daily brushing and flossing, and use of antimicrobial agents like mouthwashes, can help prevent the formation of dental plaque, but in severe cases, antibiotics and surgery might be needed. Alright, as a quick recap, gingivitis is caused by infection and inflammation of the gingiva that can grow to involve the tooth-supporting structures, which is called periodontitis. When dental plaque builds up near the gum line, it can allow bacteria to invade toward the root of the tooth. Diagnosis is done via visual inspection, x-rays, and probing the gums. And treatment of severe cases might include removal of the infected tissue, antibiotics, and surgery.